research extension and the academic or teaching aspect. And one of the things that you will notice about the Ag Center logo and the one that we're proposing for the College of Agricultural, Family, and Consumer Science.
Ms. DeLesso Alford,
Present.
Dr. Tavell Kendall, Representative Dustin Miller, Ms. Alma Stewart,
Present.
Mr. Christopher Tyson, Dr. Rivars, Derek Rivars, Dr. Corey Hebert,
I'm here.
Ms. Lenore Caroli,
Here.
Dr. Keith Ferdinand,
Here.
Councilwoman Helena Marino, Councilwoman Cindy Nguyen, Ms. Sadie Finkel, Dr. Alicia Bates,
Here.
Dr. Janine Thomas,
Here.
Dr. Leanne Fowler,
Here.
Ms. Cindy Snyder, Ms. Kathleen Tate,
Here.
Dr. Lisa Van Hoos, Ms. Shalina Davis,
Here.
Mr. Michael McClanahan, Connie Arnold, Dr. Faye Grimsley,
Here.
Ms. Erica Rogers, Mr. Frederick Thomas, Dr. Demetrius Porsche,
Here.
Ms. Judy Reese Morse,
I'm here.
Dr. Earl Benjamin Robinson,
Here.
Dr. Peter Fox,
Here.
Dr. Kathleen Kennedy,
Here.
Dr. Robert Maupin,
Here.
Dr. Christy Anderson,
Here.
Dr. Takesha Davis, Dr. Amanda Dumas,
Here.
Dr. Amy Lesson,
I'm here.
Dr. Ebony Price Haywood,
Here.
Dr. Margarita Echeverry, Ms. Christian Engel, Ms. Tina Granger, Ms. Catherine Haywood,
Here.
Reverend Theron Jackson,
Here.
Mr. Rudy Macklin, Dr. Orlando McMeans, Dr. Rhoda Reddick,
Here.
Dr. Simone Rambati, Dr. Jacqueline Harris, Dr. Peter Kasmarskit,
Here.
Dr. Samuel Sarpong,
Present, Daniel.
that's it, Dr. Williams.
Thank you so much. Before we begin, just a reminder for all of you to mute your phones, please, so that distractions are, of course, limited. Also, if you have any public comments that are germane to this agenda, we ask that you send them to public_comments at sus.edu, or of course, you can log on to our website at www.sus.edu. You can click on the Louisiana COVID-19 Health Equity Task Force and submit your comments there. Also, for all of you who are on the call, if you would like to provide comments, remarks while during our presentations, you can always submit those through the chat, where we have staff monitoring those as well. Again, want to welcome you all to today's meeting. We have a couple of special presentations, one being from Dr. Welch, who's going to cover Louisiana Vaccine Action Collaborative and provide an update on that. Also, Dr. Ebony Price Haywood is going to talk about hospitalization and mortality among Black patients with COVID-19, and she's with Ochsner Health Systems of New Orleans. After that, we're going to do some housekeeping and have some updates on our communications and messaging, racial disparities in healthcare costs, and then our task force funding project. Dr. Kimberly Robinson will provide an update. With that, I am going to turn it over to our co-chair, Dr. Sandra Brown.
Well, hello, everyone. Can everyone hear me? Yes? Great.
Yes. Hello.
Great.
Hello.
We welcome you to our COVID-19 Health Equity Task Force. I bring you greetings. Dr. Levy, are you on?
I'm here.
All right. You want to say hello to everybody?
Hello, everyone, and welcome back.
All right. Thank you. As Dr. Williams said, we have a full agenda, so we'll go and get started with our first presentation. Our special guest today is Frank Welch. He is with Louisiana Vaccine Action Collaborative. LDH has appointed a Louisiana Vaccine Action Collaborative Committee, which is led by Dr. Frank Welch, who serves as the medical director of the Office of Public Health Immunization Program. So Dr. Welch is here today to provide the task force with an overview of the Louisiana Vaccine Action Collaborative. Dr. Welch?
Good afternoon, everyone. I just want to make sure everyone can hear me.
Yes, we can.
Excellent. Thank you. And wow, I realize how long I've been at this job when I see how many people not only have I worked with before, but several of my former bosses as well. So I hope that I can bring you some useful information, and I actually would really like your feedback as well. So I know there's a presentation. I think that's going to come up here in a minute. And first, I'd like to just say thank you for having me, but also just know that several members of the committee that I'm, the Vaccine Action Collaborative, are also on this committee as well. I'm here as a guest of Dr. Phillips, who's the Secretary of Health, but also Dr. Benjamin works with us on the Vaccine Action Collaborative as well. So I brought you about 20 slides today. I'm going to move through those relatively quickly, but again, if you do have any questions, please just ask me. Do you want to pull up the slide singly, and then I will just say next slide? There we go. So I was going to have my partner with the immunization program here today, and she's been called away to another meeting. However, the Vaccine Action Collaborative is just that. It's a collaborative. Although I'm here representing the collaborative, there are over 50 members of that collaborative, all working not only with the group, but 4 subgroups as well to give input on the COVID-19 vaccine. Next slide, please. So what I'm going to talk to you all about today is what we've all been hearing about, quote unquote, Operation Warp Speed. And just to let you know, I hate that name. And then I'm going to talk about the Vaccine Action Collaborative, vaccine allocation and receipt, vaccine distribution, vaccine priority groups, vaccine accountability, vaccine administration, and vaccine communications. And just to let you know, in a smaller form, we have been working on this plan to get COVID-19 vaccine in Louisiana for about 3.5 months now. The first meeting was way back in June, not nearly with the largest group, but we have been planning not only based on our experience of providing immunizations in the state of Louisiana, the information we learned from the H1N1 vaccine distribution, but also information, and technology has changed since then, and the requirements that are being released by the CDC and HHS. I just wanted to mention that because many people know that the CDC just released the guidance last Wednesday, 3 days ago, but the state of Louisiana has been planning for 3.5 months for this now. Next slide, please. So Operation Warp Speed is the federal program. What it does is it aims to deliver 300 million doses of a safe, effective COVID-19 vaccine by January 2021. That is not going to happen, just to let you know. We believe that possibly the first doses of vaccine will come to Louisiana or to the United States, possibly in early November, probably a little later, but as many of you heard, by the time vaccine is available to the general public will probably be spring of 2021. However, Operation Warp Speed is a federal program. It's a partnership between HHS, the CDC, the FDA, the National Institutes of Health, and the Biomedical Advanced Research and Development Authority and the Department of Defense. And what they did is they took a bunch of our tax dollars and gave it to a bunch of vaccine manufacturers and said, do your best to produce a vaccine for COVID-19. We do believe that there will be between 8 and 16 vaccine candidates. I think one of the biggest misinterpretations that people have is that there is a flu vaccine or a tetanus vaccine. There are actually multiple different vaccines with different indications. And what I mean by that is they test them on different people. There will be between 8 and 16 COVID-19 vaccine candidates. We think initially there'll just be 1 or 2. Next slide, please. So the Vaccine Action Collaborative here in Louisiana. Our goal is to plan for the equitable and organized receipt and distribution of any COVID-19 vaccine in order to do 2 things: reduce the spread of the virus and reduce comorbidity and death in vulnerable populations. We have lots of members. Again, there's more than 50 members currently: public health, education, academia, GOSEP, the medical institutions, and also community stakeholders. Again, it was formed back in June 2020, and we have 4 major subgroups: communications, logistics and operations, planning and prioritization. We actually had a 5th subgroup, health equity, which is why I'm here today. However, it was decided that that was not going to be a separate subgroup, and we would spread health equity within each of these subgroups to ensure that health equity was being addressed at every single step of the way, every single step of the planning, prioritization, communications, and logistics. Next slide, please. So what we aim to do: communicate with our stakeholders, then identify, define, and estimate the number for vaccine priority groups within the framework of national guidance. What that actually means is the CDC and the ACIP, that's the Governing Board for Immunizations in the United States, gives us guidance on who should be the priority groups and what vaccine is appropriate for each of those groups. We will follow within that guidance and apply it to the state of Louisiana, and then any uniqueness we have within Louisiana, we will be responsible for identifying that. One of our goals is to immediately allocate vaccine as soon as it becomes available in Louisiana, not wait a single day. As you might expect, given a very limited amount of vaccine initially when it comes to Louisiana, we are going to have to prioritize. There will be certain groups who are first in line, and then other groups will fall in behind those groups. We will not only use our existing process. In the state of Louisiana, we have excellent vaccine receipt and distribution, but we will have strong alternate and contingent planning, and I'll explain why that is important. We need a prompt, secure distribution of the vaccine, preserving the cold chain. And what that means for people who don't know is vaccines often have to be treated very carefully from the time they leave the manufacturer to the time they're at your doctor's office, ready to be administered in your arm. And that's called the cold chain. And it is very important to preserve that cold chain. Unfortunately, one of the candidate vaccines coming to Louisiana or the United States might in fact require what we call the ultra cold chain. And what that means is it has to be shipped and delivered on dry ice. And we don't have any other vaccines that are handled that way. We used to a long time ago, but you can imagine that in and itself is a logistical challenge that we are planning to meet. We want to securely dispense an effective vaccine using hospitals, doctors, pharmacies, public health units, federally qualified health centers, closed and open pods, and mass vaccination partners. And all throughout this process, we want to make sure we collect and depict data throughout the vaccine response to inform better decision-making, not only who is getting the vaccines, where our pockets of need are, and where we need to target resources. Next slide, please. I'm going to go through just real briefly. This is what we do for every vaccine, but this is what we're going to do for the COVID-19 vaccine. The first thing you do is when you become aware, a vaccine doesn't come to the state of Louisiana and then we decide what to do with it. The vast majority of vaccines from the manufacturer, we tell them where to send them and they go directly. They do not come and stop in the Office of Public Health and then get distributed. The vast majority of vaccines go directly to where they are going to be administered. However, most of the time we have to tell the company where to allocate that. So not only are we going to work within the national framework, within our priority population, it will depend on the preparation and indications. And what that means is, again, not every vaccine can be given to everyone. In fact, we hear a rumor that the first couple of vaccines have not been tested in pediatric populations. So you can't take an adult vaccine and give it to a child. So each vaccine will be have different indications. Say they tested on age 15 to 60. You can only give it to that population. So that's what they call the indication. Each of these vaccines will have a different indication. There are different amounts. Say, for example, one vial might have a single dose of vaccine in it, where another vial might have 10 in it. And so you can imagine all of these things make a difference to where we might send it to in the framework of who is our priority. And I'm going to give you a little example of that. During H1N1, we planned very extensively for our priority populations, and we were going to send our first doses of vaccine to hospitals that had very sick people, elderly people, because they were at serious risk of H1N1. However, the first doses of vaccine that we got in Louisiana were for healthy children and not for adults. And so we have to work not only within our priority populations, but with this specific vaccine that we get at the time. In addition to that, another challenge is going to be that some vaccine will be allocated directly to certain places. We don't know who those places are yet, but I suspect that those would be our highest risk residents in Louisiana, which is nursing home residents and nursing home staff. So we do believe that there's a federal program that is going to distribute vaccine directly to those locations, although we're not sure exactly. The number one priority for the Vaccine Action Collaborative currently is identifying those priority groups. We've been given a list of who might get the vaccine first. And again, what you want to do is identify those places where people are most at risk of getting and acquiring coronavirus, and then those people who are most likely to suffer complications from it. The vaccine receipt will go through a company called McKesson. And there is a possibility, though, that if a provider is ordering less than 100 doses, the state may play a role in breaking that down and sending it to people. Next slide, please. So vaccine distribution. Again, the vast majority of vaccine will go directly to the provider who it's allocated for. There may be some later on where the state has to break it down. Say a small clinic only wants 10 or 20 doses. The state may play a role in sending that to them. And again, there's going to be targeted delivery to certain locations. We do think that those might include nursing homes, congregate settings like prisons, and then possibly places like where we've seen large outbreaks, like large processing facilities, like meat processing facilities. They may have direct distribution as well. Next slide. So the vaccine recommendations, who is going to get the vaccine? And again, it's going to depend on the indication of each vaccine. The ACIP guides us in the United States on who each vaccine is indicated for. The initial guidance is going to be for critical workforce, and those are people we know are coming into contact with coronavirus every single day, and those are frontline healthcare workers. They're going to be first in line to be vaccinated. And also, they will be the people who are vaccinating other people. So a rule in immunization practice is the first person you vaccinate is going to be the person who is then going to continue to vaccinate other people. After infrastructure workforce, then people at the highest risk for severe outcomes. Currently in Louisiana, those are nursing home residents. But then as we go down the line of priorities, we're going to recommend people who have those other comorbid conditions that we know put them at increased risk of illness or death from coronavirus. They are going to be in line right after them. It's always important to remember equity with the COVID-19 vaccine. COVID-19, as you all are aware, does not affect each population equally. So it's important in a vaccination campaign to make sure you prioritize those people who, A, are more likely to get coronavirus, either because of occupation or the fact they have to work or where they work, but also those people who are at increased risk of complications. There is a preliminary framework for equitable allocation of COVID-19 that we will work within. And within those priority groups, the main goal is to reduce transmission and reduce morbidity and mortality. Next slide, please. So here's what that generic phasing looks like. And just know, within the Vaccine Action Collaborative, we have taken each of these phases and you should see the spreadsheets of estimating these populations within Louisiana. But it's not just about estimating the population, say how many nursing home residents we have. We need to not only estimate that population, we need to know exactly where they are, and we need to also estimate how we would get vaccine to them, but not just that, how they would be administered the vaccine. We have a saying in immunization that it's not the vaccine, it's the vaccination that matters. So you can just see, in general, phase one is the jumpstart phase for those high-risk workers in healthcare facilities where we know they are being exposed to coronavirus. In phase 1B, the people of all ages with those comorbid conditions like high blood pressure, obesity, diabetes, heart and lung conditions that we know if they got coronavirus, they are much more likely to be sick from it. Older adults living in congregate or overcrowded settings like nursing homes. Then you can see in phase two are critical risk workers. Again, those who are in industries that are essential to keeping our economy and our society functioning. Teachers and school staff would fall in phase two as well. Then other people with moderate risk factors to put them at increased risk of getting coronavirus. Then other older adults as well. People in homeless shelters would fall in phase two as well. People with physical and mental disabilities. And then also in phase two is people in jails and congregate settings, detention centers, and similar facilities. In phase three would be young adults, children, and workers in industries essential to functioning of society and at increase of risk and exposure that weren't vaccinated in phase one and phase two. And then in phase four would be everyone else who did not receive a vaccine. And again, the reason for these phasing and priority groups is not that I don't believe everyone shouldn't receive a vaccine, but we believe that the initial quantities of vaccine are going to be limited. So you have to go through this prioritization. And this was truly one of the most difficult things we had to do during H1N1. Next slide, please. So how are we going to account for this? Fortunately, in Louisiana, we have one of the best immunization registries in the country. We are able to register, collect demographics on, and say which vaccine each person got. The technicality with COVID-19 that's going to make it more difficult than H1N1 is the vast majority of COVID-19 vaccines are a 2-dose series. And unfortunately, each of these vaccines may have different timing between vaccine. If you get a particular vaccine, there may be an interval between 21 and 28 days until you receive your second dose to be fully vaccinated. There is one vaccine who's only going to be 1 dose. of that. So we have that challenge as well. But with our link system, we do have the ability to do reminder recall. We will know who got what vaccine. We will know when they got that vaccine, and we will be able to remind them when their next dose of vaccine is due and what vaccine they need to get. There is no crossover, meaning if you get a certain vaccine on day 1, you can't get a different type of vaccine on day 28. You have to get the same vaccine. So you can imagine this increases the challenges we have. Fortunately, the LINKS Immunization Registry is going to help us with that. Next slide, please. So who currently administers vaccines in the state of Louisiana? We have incredibly strong vaccination partners. We have our VFC providers for pediatric patients, hospitals, doctors. All pharmacists in Louisiana can give vaccinations above the age of 17, but they can give flu vaccine down to the age of 7. There's currently some legislation that would allow pharmacists to vaccinate with coronavirus vaccine down to certain ages, possibly pediatric vaccines as well. Again, the challenge with that is we're not aware that there is a pediatric vaccine for coronavirus yet. That may come out in later phases. We have our public health units. We have our school-based health centers. We also have a bunch of mass vaccinator partners. These are those buses or teams that go around to large industries or schools and help us vaccinate against flu. We are preparing all of these places for the COVID-19 vaccination campaign. But in addition to that, we're recruiting new partners all the time. In fact, just last week, we onboarded more than 30 new partners to be vaccinators for COVID. The way you do that is to communicate that if you want to be a vaccinator, contact us. We need to identify who they are. We need to register with them. We need to credential them, and we need to train them, not just for the vaccination process, but also to document that vaccine. There's going to be strict documentation required by the federal government in this campaign. In addition to that, there is some, I don't think it's legislation, it might be a practice rewrite. In most states, EMS providers, there are different levels of EMS providers, and we're working with the EMS community of Louisiana to make sure that those upper tiers of EMS providers can also be vaccinators as well. Next slide, please. So administration, again, we're going to have our traditional providers, non-traditional providers. We may, in fact, depending on the type and indication of vaccine we get, we may set up pods. Many people are familiar with our mass vaccination exercises that we do every single fall with our partners. In fact, we're having flu mass vaccination exercises within the next month in every single region and almost every single parish. And the unique part about our flu pods this year is they are going to be under COVID-19 restrictions. So we're using these mass vaccination exercises as an exercise to help us plan for the potential of having COVID-19 mass vaccinations as well. Again, there is going to be direct vaccination of some populations that are not yet defined to us, although I do have an indication that nursing home residents and nursing home employees will be this direct route. Whether there's other direct routes, we do not know yet. Next slide, please. So as all of you know, communications is going to be the #1 challenge of COVID-19 vaccine. It is the critical component. We are planning a large media outreach with providers, stakeholders, and the public in multiple formats. We got a very large grant to assist with this. I don't think I have to tell everyone on this call that coronavirus in general has been controversial, but COVID-19 vaccine falls into that place as well. In order for people to have trust in a vaccine, we have to know that it is safely produced, that it is safe to inject, that it actually provides the immunity that it says it's going to, and that there is public common good in people getting the vaccine. And to be honest with you, we are not there yet. In fact, I would say that as of 2 months ago, we're further behind. So there is going to be a large vaccine communication component to this. We're going to talk about vaccine safety, how vaccines are produced. It's one of my biggest complaints with the term Operation Warp Speed. might indicate to some people that steps were skipped, which they weren't in terms of producing the vaccine and the safety testing of vaccines. But also, getting those doctors out there to recommend the vaccine and to get people to have enough trust to take the vaccine. So communications is one of our largest subgroups in the Vaccine Action Collaborative, and probably the most challenging, as I'm sure you all are aware. Next slide, please. So how is health equity being included in COVID-19 production and distribution? We have members from the LOPH Health Equity Task Force. Several people on this call, actually, in this group, are actually on our Vaccine Action Collaborative as well. There are members from the Immunization Program, Office of Community Partnership of Health, the Board of Pharmacy, the Governmental Office of Indian Affairs, and the Bureau of Community Preparedness, but we've also recruited multiple academic partners as well, and many of them specialize in health equity and disparities as well. So we're trying to include those kind of people in every single one of our subgroups, in every single one of our steps. It really is a challenge not knowing what vaccine we're going to get. Targeted outreach to any particular population is going to depend on the indications for each vaccine. We have representation from LPHI, Tulane, LSU, Xavier, Louisiana State Nursing Association, Nursing Home Association, the Home Care Association, the American Academy of Pediatrics. We have EMS providers, Osher and other hospitals, lots and lots of stakeholders. Again, 50 different people represented on the Vaccine Action Collaborative. All work groups are charged with including health equity in all of their work to ensure we reach all populations and provide access to vaccination regardless of any barriers. Communication and outreach, we're having regional town halls to educate various populations on COVID vaccine, working with community and religious leaders to identify and reach marginalized or less accessible communities. And Dr. Benjamin is instrumental in helping us with that, not only with COVID-19 vaccine, but flu vaccine as well. So appreciate and his partnership and his commitment to not only COVID-19 vaccine, but influenza vaccine as well. In logistics and operations, we do have the potential for mobile strike teams, which are carrying over from our testing strike teams. And that might be important when we identify pockets of needs or populations that may not have access to the vaccine. We may be able to send strike teams to locations in those areas. Planning includes over 30 organizations to ensure a variety of groups are represented and involved in creating the COVID-19 playbook. COVID-19 playbook is the federal plan that we need to submit that was just announced 2 days ago. Again, we have done much of that work already, but we are developing our playbook using our 30 partner organization, and then prioritization and allocation. Again, trying to develop logistical plans to create temporary vaccination clinics to reach those hard to reach populations that we have identified through our data collection. Next slide, please. So this is a slide, what we don't know, and this is the disappointing part of what I'm going to tell you. We have been planning for 3.5 months, and a lot of our planning has been based on, again, previous events, our experience distributing and allocating vaccines in the state of Louisiana, but we really do not know much yet. We don't know the vaccine preparation we're going to get, and that includes how many doses are in each vial, how you schedule each vaccine, when we'll get a vaccine, are the vaccines interchangeable, the storage and handling of each vaccine, the minimum quantity of each vaccine, meaning does it come in a box of 10 or does it come in a box of 1,000? The indications for each vaccine, and again, we're not aware of any pediatric vaccine that's being developed yet. The interval between vaccination and protection, meaning once you get these 2 doses, how long can we say it is that we can consider you protected? And then in addition to that, we don't know how long after you are protected with these 2 vaccines, we can say you have immunity. And then this last bullet, there was in development a federal system to document vaccines. However, they've had some challenges in producing that federal system. So I'm very proud of our link system, and I will say we are going to use our link system to document vaccine doses. Next slide, please. This is just we did receive a first and second supplemental award for vaccination for planning for COVID-19 vaccination. 75,000 is going for testing supplies, equipment, data visualization software to make sure this link system is capable of working in all these new providers' offices. We have hired 2 people to launch a social media and marketing campaign. And again, that extensive communication campaign to educate people about the vaccine and promote vaccination. We are working with the LSU National Center for Biomedical Research and Training to work with our partners to tabletop and do a couple of drills when the vaccine comes to make sure we are prepared to do that. We have enhanced our link system and developed multiple provider training modules to onboard new providers, but also to get them to use a specific screen on our link system to just administer COVID vaccine. And then again, we are hoping to have quite a few mobile vaccination teams. This is to reach those hard to reach populations that we've identified that either are not getting the vaccine, don't have access to the vaccine, they're in a community that doesn't have a lot of vaccinators. We are working extensively to have mobile vaccination teams to set up pods to try and get vaccines in hard to reach areas and populations that are hard to reach. Next slide, please. So we have a lot of strengths in Louisiana. We have been planning for the COVID-19 vaccine campaign since June. Our campaign will be based on communications and strong partnerships. We do have really strong community partnerships with academia, associations, government, private sector, and all of our stakeholders as well. The Office of Public Health and our partners conduct mass vaccination exercises every single year. This year is no different. Again, this year's mass vaccination exercise across Louisiana will be in a couple weeks. It will include probably more than 40 or 50 sites. And again, they will be following COVID and physical distancing restrictions in order to prepare for COVID-19 vaccination moving forward. We have an excellent immunization registry system. And again, the pre-planning for COVID-19 vaccination is based on years of doing mass vaccination exercises, what we learned in H1N1, and planning and tabletopping since then. Next slide, please. So next steps and timeline. We work daily with the CDC and HHS. We have a weekly standing call with them, attempting to get information about when we will receive a vaccine, what that vaccine will look like, who it's for, how it's going to be stored and handled. We will continue to plan with the Vaccine Action Collaborative with each step of the process. We want to provide communication and outreach to our stakeholders at every step of this process. We are preparing for our first doses of vaccine to be delivered November 1st, 2020. I'm not sure anyone on the Vaccine Action Collaborative thinks that date will happen. However, that is our date to be prepared to get vaccine. We will continue to evaluate and improve the process as we move forward in this campaign. And again, communicate every step using the data that we've collected with providers, the public, and our stakeholders. Next step. So I see there is some chat questions. Let me go to those. My old boss, Dr. Davis, has joined us. Hi, Dr. Davis. Let's see. Okay. So and also Dr. Rebecca Gee. A great deal of mistrust about vaccines, how we work ahead of time with communities to ensure questions and concerns are addressed. Will Louisiana apply a safety standard separate from federal standards if it seems that FDA is fast-tracking the ways that defy the usual process? And the answer is absolutely yes. Dr. Guidry, as the state health officer, has made a promise that we will not distribute a vaccine in Louisiana that has not undergone the proper phase 1, phase 2, and phase 3 safety trials. and we can guarantee that it is at least undergone those 3 standard FDA processes for safety. Ideally, we would have an evidence-based immunization campaign with particular attention to people of color and other communities disproportionately impacted by the pandemic. Absolutely. And that is the inclusion of health equity and targeted campaigns within Louisiana to find those communities, make sure they have access to the vaccine, and if they don't, send strike teams there.
So Frank, instead of answering, I would just say, I think it's important that we do this ahead of time. And one of the things we've asked for in some federal conversations and talking to Senator Cassidy and others is to get grants to us ahead of time so we can do some work with communities and figure out what some of the issues are and help address them ahead of time and make sure we have culturally and linguistically appropriate materials. So we're not waiting for the vaccine to come and then developing them. So we'd love to know that. And then of course the trust eroding. And then finally, I did want to say, and I've been speaking with several colleagues, including yesterday, the dean at Tulane, and I've spoken to colleagues at Oxford, and I know here at LSU, is that although I think this is a fantastic plan, by the way, and Frank, you are one of the country's best, and I know how lucky we are to have the tremendous staff that we do, but some of the partners that you've indicated are in the loop, I don't think are. So I think we're going to need to do a little bit more work to get the folks who are leading clinical systems and the academic medical centers in the loop so that we can be a part of it. I know we have, and I know Tulane and Oxford and others, I'm sure, have experts that would love to be a part of it and be involved. And I think we'd like to be looped in and maybe have a discussion after this call as to how we can create a little bit better communication. So I'd love to be a part of helping with that. And I thank you and your team for all this extraordinary work.
Actually, that is my last comment. Actually, this Vaccine Action Collaborative was formed over the past 3 months. My last ask to this group is, what I'd like to do is send everyone the current members of the Vaccine Action Collaborative, and if you review that list and see someone, I know I'm getting a message from Dr. Foss, which suggests that he might have people to add to this. We're adding members every single day. Some people feel like they have given their input and are dropping out, but we're adding new people all the time. So what I'd like to do is send you the current list of the Vaccine Action Collaborative. And if you have suggestions to add, please do so, because it is an open group. Again, I'm not in charge of the collaborative. We are in fact a collaborative. So if you feel like you have people that you want to add, please send me those names after reviewing the list. The mistake I make with this presentation is always just giving sort of an abbreviated list of who's involved. I think if you all saw all of the names that are on there, you may be able to identify certain people who could really provide us some great input.
So Frank,
And I think there are a couple additional questions. What is the sample size of the present vaccines that are being considered, and what is the conventional phase 3 sample size in prior vaccine development? It is the same, but it's about 30,000. In phase 3, they test on 30,000 people, and that is the same. If you guys want me to tell you exactly what has been abbreviated in Operation Warp Speed, I can do that. Typically, when a company develops a vaccine, what they do is they go through phase 1, meaning if we inject it in you, do you fall over? Do you suffer some sort of bad event? Phase 2 is we test you to see if what we injected in you, did it cause immunity? Did it do what we thought it was going to do and give you immunity, at least an immune reaction to the vaccine? And then in phase 3, what they do is expand that to a whole bunch of people and say, did it actually protect you from disease? And all 3 of those phases are being followed for all of these vaccines. But you can imagine when a company invests in a vaccine, they have to invest their own money. So what they do is they do phase 1, phase 2, and phase 3. And then if it passes all of those phases, then they go into production and spend their money and say, we're going to make it for the general population. But since our tax dollars were used to produce the COVID vaccine, what they did is They take phase 1 and phase 2, and if a vaccine passes phase 2, then they start production while they're in phase 3. They're still doing phase 3, but at the end of phase 3, if a vaccine makes it out of phase 3, then they've already made the vaccine because they didn't have any financial investment. They used our tax dollars. However, if a vaccine makes it to phase 3 and it is not effective or we don't want it, they have to throw all of that away. They are not going to release a vaccine that hasn't made it through phase 1, 2, and 3. The warp speed is the fact that they used our money rather than their own. So just to let everyone know, all of the steps are being followed.
Yeah, Frank, that was my question. Dr. Ferdinand, the sample size of 30,000, how close are you to any of the present vaccines to that type of a phase 3 sample size? Because that will tell you the time it will be ready. If you're going to say you have something ready for the first week in November, then you have to be doggone close to getting a 30,000 phase 3 sample size. If not, then you're not just warp speeding the process, you're cutting short the process.
You are absolutely right. And in fact, there were 2 vaccines that were, scheduled. And again, this isn't a state process. This is FDA working with these private companies. And many of you saw a couple weeks ago, the AstraZeneca trial was halted because of a severe adverse reaction in a phase 3 trial. That was one of the vaccines that they told us was going to come November 1st. So I don't have any expectation that a vaccine is going to be delivered November 1st. And I don't think any of you should either. I think that possibly we could see a vaccine by mid to late November, even early December, but widespread vaccination is probably not going to be available until mid to late spring or even early summer next year.
So Frank, this is Tom Levy's co-chair of the task force. I appreciate this presentation. I don't have context for how much this differs from the normal process of vaccination, recruitment to vaccinate for influenza. But given the low percentage of uptake of that vaccine, what's being done differently to ensure that we'll get a higher rate of uptake?
Yeah, that's really challenging. I have worked in vaccination policy for about 25 years now, and really the thing that helps people or in large groups take a vaccine is trust, and you need strong leadership, and you need information, and you need reliable sources to give you information. We found that the most reliable source of recommending vaccine is your personal physician. So we do have a campaign with physicians to make sure they're recommending the vaccine. I think, and I'm just going to be honest with this whole task force right now, I think I need to be confident about the vaccine. And since we haven't been given any information yet. So I haven't seen the trials, I haven't seen the vaccines, I haven't, So before I recommend a vaccine, I'm going to want to see, those phase 3 trials. And unfortunately, we don't have any of that information yet. So I think it's going to be a process by which we use continuous education using valid data, and then data about how well it works. And then you see in communities or people, let's say we have a very effective vaccine that works very, very good. We're going to start to see decreases in coronavirus in those subpopulations and use that kind of information to reach out to other populations, trusted sources to help them recommend the vaccine. I don't see, and I see several people in the chat are basically saying there's really low confidence in a COVID vaccine, and I agree with you.
But what is the collaborative working on this issue? I mean, what steps are you taking to try to counteract this? I mean, we know African Americans have been disproportionately impacted. We also know African Americans have a lower rate of influenza vaccine. I would predict that this is going to be the case here as well, particularly with messaging such as Operation Warp Speed, which emphasizes the speed at which is being manufactured rather than the accuracy and safety. Also, you said that the state health officer had said that that they would not release the vaccine to the state. Is there a structured process by which this phase 3 trial is going to be evaluated within the state? How exactly will that get done, and who will be involved in weighing in on that vetting process?
So to answer your first question is, it's going to be a challenge. I wish I had a magic wand that made people trust vaccines. We have that as a daily challenge with people. There is lots and lots of misinformation about vaccines that really do work and do work well. This is incredibly challenging about vaccines. We don't even know what they are yet and haven't seen that data. So yes, there is a part of the Vaccine Action Collaborative that works on communication, and one of their charters is to reach out to hard to reach communities to try and get information to them. Again, I think it's going to be through trusted sources, working with people like Dr. Benjamin, faith-based communities, and you know, I think it's a real challenge that I don't have an easy answer to. I can't counteract misinformation or challenging information coming at the national level with state-based information to say, you know, just make people say there's a difference of opinion. So it's going to be a challenge, and one that I think our Vaccine Action Collaborative is going to have to work very hard at, to not only get people to trust it, but to take a few steps back and say, yeah, again, I think we're starting from a few steps back than we normally start from with normal vaccines. The state health officer would have the ability to evaluate phase 3 clinical trials in any vaccine, working with the FDA and our Department of Epidemiology to know, you know, and I think what it is would be that if an FDA went through the normal process and approved a vaccine, that would be one that we would present to the citizens of Louisiana. If that process was somehow skipped or altered in some way, I think he would have something to say about it.
Are there any other questions for Dr. Welsh? We thank you, Dr. Welsh, for your very thorough presentation and for our candid discussion today. We do have 3 members of the task force who will serve on this collaborative, and that's Dr. Earl Benjamin Robinson from LDH, Ms. Judy Reese Morse from Urban League of Louisiana, and Dr. Keith C. Ferdinand from Tulane University of Medicine. And these 3 members of our task force will be reporting to the task force updates and keep the task force informed. We will have a standing agenda item with them on the agenda so they can keep us abreast.
This is Terry Davis. Can I ask a quick question? Do you know the percentage of minorities enrolled in the clinical trials?
So again, the real challenge, and again, I sort of present myself as some sort of information source, and my true challenge is I don't have information. We have not been given information on the clinical trials, any particular vaccine, when we will get it, what that vaccine is, who it's good for. But what I will tell you is, if and when I get that information, I will share it with you all. I have heard sort of in the background that minorities and hard to reach communities and people with comorbid conditions are not effectively or haven't been included in the clinical trials at a level that some people would like to see. But again, I haven't seen that yet.
Frank and Terry, this is Dr. Gee. One thing I did want to mention, I just sent to everybody the link for the Johnson & Johnson trial. This is one that is a vaccine that's a single dose and does not require the type of cold chain process that Frank outlined, and it's a promising one. They've moved to phase 3 trials and intend to enroll 60,000 people, but it is important that we have diverse representation. So I think one thing this group could do is take this link and share it and ensure that we have honest conversations with folks in the community, because enrollment depends on, in part on leaders like us and our participation in encouraging it and having honest conversations. So this is a link. It tells you where a New Orleans auctioneer will be providing it, and it's being provided in 2 locations, it appears, in Louisiana now. So just more information, and if we want to maybe at a future date talk about this and how we as a group could help, because it is very important that we have diverse enrollment so we understand what this vaccine does at a population level. But we also
Dr. Brown, I can say what I have to say in 30 seconds. The idea of having the systems to deliver the vaccine are good, excellent, and appropriate. You cannot ask the trusted voices, and I would include myself as one, to hype a vaccine when you don't even know the phase 3 sample size and what were the complications that were seen. In 1976, Gerald Ford pushed out a swine flu vaccine. There was mass immunization, and Guillain-Barré, which is a type of paralysis, was then noted once the doggone thing was released. So the trusted voices will say to you, it's good that we're setting up these devices to deliver vaccine. I'm not going to tell my patients and my people in New Orleans to take the shot until you have that data.
Well, it's a push and pull, right? Because if we don't participate in clinical trials, then we don't know. So I think I agree with you that we've got to review the data, but as professionals, we've got to have those discussions, because if we don't participate at all in clinical
I wasn't talking about the clinical trials participation. I was talking about the delivery of a vaccine without even knowing the sample size of the phase 3 trial. If it's not a big enough phase 3 sample size, you don't know if the doggone thing is going to have efficacy and safety.
Could not agree more. In fact, I sent a letter to FDA Commissioner Stephen Hahn saying that exact point, and I agree with you on that.
But
Dr. Wilkes, I agree with everything that's been said, and I agree with Dr. Ferdinand, and I think we all are right at that point where none of us will recommend this unless we're guaranteed. But I'm involved with a group that's actually surveying and convening focus groups right now to uncover the barriers that people are expressing to have that out front. And these are mostly minority-based groups that we're doing to get their perception so we can know exactly what is on the mind in a tangible way, so we can see what those and address those barriers. I think a lot of us know what they are, and I'm old enough, like Dr. Ferdinand, to remember the swine flu in my older patients too. That you have to really, as I tell my medical students, half of being in medicine is you have to be a salesperson and convince people to help them, to help themselves, as well as what we're trying to accomplish. So as that group meets, I think you have the process, the workflow with your group is great, the distribution and all that, but getting people to want to take it is going to be the challenge, as everyone is saying. That group hasn't formally announced yet, but when it does, I'll share it with the larger group.
My concern is about this timing of the release of the vaccine. They're not going to do that unless they have enrolled in clinical trials the right percentage of minorities. Pfizer, I understand, is cutting off white enrollment on Monday, but the Black and Hispanic enrollment is drastically down, but they can't release those vaccines until they get adequate sample, can they?
They can release and no one's going to take it if you don't have that data. I'm not going to take it, and I'm not going to recommend it.
Okay. Well, thank you again, Dr. Welsh. You're welcome to stay on and continue attending our meeting, or you can sign off at your leisure, but we'll continue to dialogue, and we look forward to staying abreast and apprised of your work through Dr. Benjamin, Ms. Morris, and Dr. Ferdinand. Thank you again.
And Sandra, if you would just assist me, if I could send you that list of the current Vaccine Action Collaborative. And again, if anyone has anyone they would like to participate, please send me an email back and we'd be glad to include them.
Thank you. Thank you again.
Thank you.
Next on the agenda is Dr. Ebony Price Hayward. She is a member of our task force. If you remember, Dr. Hayward presented her findings on a study that she conducted on hospitalization and mortality among Black and white patients with COVID-19 at Ochsner Health System in New Orleans. She is here today to provide the task force with an update in response to a story recently published by ProPublica regarding Ochsner's hospice practices. She has presented this update to the Louisiana Legislative Black Caucus, to LDH, and to Dr. Levis and myself. We invited her today to present the updated information to the task force. Accompanying her are representatives from Ochsner, Dr. Leonardo Sion, who's Chief Academic Officer, Dr. Robert Hart, who's the Chief Medical Officer, and Deborah Grimes, who's the Chief Diversity Officer. Dr. Price Hayward.
Thank you. Yeah, can you hear me and see the screen?
Yes.
All right, good. Thank you again for inviting us back. And as Dr. Brown said, I presented this information to you originally in June after we published our findings in the New England Journal of Medicine. But I am returning today to look at that information and to share some new data with you through a different lens. As Dr. Brown mentioned, there was an online news site, ProPublica, that published an article September 2nd questioning Ochsner's policies and directives related to end-of-life care for COVID-19 patients. Because of that initial report, the Louisiana Department of Health visited the Ochsner Medical Center West Bank facility in New Orleans to review the care the team provided. After a thorough review of the procedures and practices, LDH found no deficiencies with the team or the care that was provided. They had actually also surveyed 2 hospice companies that were mentioned in that story and reported no deficiencies with them as well. We were actually sincerely appreciative of LDH taking the time to conduct a thorough review, an independent review, for the sake of the wellness, the safety of the community that we serve. From the beginning, we disagreed with the findings that were reported. And as was mentioned, we shared our results of our internal review with the Legislative Black Caucus. And I'm very grateful to Senator Barrow, Dr. Brown, and Dr. Levis for encouraging me to present that same information to you today. We are looking at some data from the New England Journal of Medicine article because that publication occurred at a time when we were at the peak of the pandemic, knew very little about the appropriate management of COVID-19. As you'll recall from that article, and as you have stated earlier today, that article was one of the first to present or to verify that the Black community has a disproportionate share of infections, hospitalizations, and death. At the time, I was asked by the senior leadership of Ochsner to review our data because the state LDH had been reporting, the state being one of the first of 5, of this disproportionate rate of death among Black patients. And so I was asked to review that on behalf of the senior suite, the senior executives, which led to this paper. As I reported back then, between March 1st and April 11th, we had 3,481 patients who tested positive for COVID-19. The majority of those patients were Black, 2,451 compared to 1,030 white patients. At the time, we had also noted among those patients who tested positive that the rate of diabetes, hypertension, obesity, and chronic kidney disease was anywhere from 1.5 to 2 times higher among the Black population compared to white patients. We had also noted that there was an incredibly high rate of emergency department testing at a rate of 65% among Blacks versus 38% among whites. There was a higher rate of Medicaid as well as a higher rate of Black patients living in low-income neighborhoods. We subsequently looked at how many of those patients were admitted to the hospital, and about 40% of them, or 1,382, were hospitalized. Of those patients who were hospitalized, we actually followed their clinical outcomes through May 7th of that year. There were, among the Black patients, 43% ended up admitted versus 31%. So that's where the first disparity was noted. In the boxes below in the flow chart, you'll see I have the actual numbers reported in the paper in terms of the number of people who remained hospitalized at the end of May 7th versus the number who had died, the number who were discharged alive. The new information that I've added here are the number of people discharged to hospice care during that time period. I was also asked by the senior leadership to go back and look at process of care measures around do not resuscitate orders being documented at the time of admission or anytime during the subsequent day of admission. And as you can see from here, I have in the margin the percent comparing white versus Black. With each of these numbers, in order to detect disparities, you look at the percent of people within a population who have a select outcome or experience a select type of process of care. So the percentages reflect numbers within each of the racial groups. So on or during admission, a higher proportion of whites, 46%, had DNR orders recorded compared to 27% of Black patients. And you can see the subsequent numbers below for each of the different groups. Most of the patients who had DNR orders actually died within the hospital. So 87.5% for white versus 84.3% for Blacks. In the middle of the slide is where I have a summary of information that's available within the paper. So again, 77% of the admissions were Black patients. We examined whether or not there was a difference in the median length of stay. And as you can see from this slide deck, there were no statistically significant difference in the length of stay for white versus Black patients. There were 326 patients that died. Again, what was striking is that close to 71% of those who died were Black. We looked at the case fatality rates, which is just a raw percentage of the number of people who have COVID-19 who died. And as you can see from the calculation, 30.1% of white patients, or 96 out of 319, died in the hospital versus 21.6% of Black patients, or 2 out of 1,063. One of the things that I've been questioned about consistently with this paper was the conclusion we drew, which was that after accounting for social demographics and number of chronic conditions, as well as severity of illness, that there was no statistically significant racial difference in the risk for death within the hospital. The demographics we accounted for were age, because irrespective of COVID-19, we know that older patients have a higher risk of death. We also accounted for gender because with COVID-19 publications from China and Italy, we were told that men had a higher rate of death. We additionally added low-income status because of the concern about essential workers and a disproportionate risk for exposure. And so that was added to the model as well. And then the number of chronic conditions have been well studied in terms of a risk for mortality in the hospital. And severity of illness, again, is a measure of how sick you were the day you walked into the hospital. When we did that analysis, the only thing that remained statistically significant was how sick you were the day you walked into the hospital. So in the bigger picture of things, we started to focus on social determinants of health and things that were upstream of the day of admission as being very critical to why we saw a disproportionate share of infection, hospitalization, and death. I did have additional information on who went to hospice care. And as you can see, there were 17 Black patients versus 4 white patients. So overall 2.2% of the admissions, and by race 4.4% versus 1.6% of Black patients. There was additional analysis that my team conducted ongoing during the pandemic and still to this day that we shared with Dr. Swanee and the senior executive team. I'm going to turn over the presentation to him to talk about how he used this data and other things that he and leaders did during the pandemic.
Thank you, and thank you again for this opportunity to speak on this topic. I'm Dr. Swanee, and I'm the Chief Academic Officer, probably more important for this conversation. I'm a pulmonary critical care physician who worked on the front lines in the intensive care unit, caring for these very critically ill patients during the pandemic, where at Osher, at our peak, we were caring for over 700 patients in our hospitals in the greater New Orleans area. One of the things that we did with the Center for Outcomes Research and our data scientists early on is we took the University of Pennsylvania's SIR model for predicting hospital utilization needs and adopted that to Ochsner. And what we did was we used hospitalizations by this time, even though the testing wasn't broad, we had a pretty good idea of the clinical syndrome of people presenting and making the diagnosis of COVID, pneumonia, and respiratory failure. So we use that to model how the peak. And as you can see on the top right, there's the amount of hospital beds utilized, not just at Oxford, but also with LCMC and at Tulane, where Oxford took care of about 60% of the patients. I share that to say that after we developed our model and found that it was pretty predictive of our hospitalization rate, we then reached out to LCMC and Tulane, and there was incredible, and EJ, and it was incredible collaboration. We actually met daily with them, talked about how many admissions that night. They shared their data for admissions with us that allowed us to make a more robust model. Now, not just for the Oxford Health System, but now for the entire greater New Orleans area. And why that's important is it allowed us to build beds as we needed. And so in the bottom left, where it says Oxford Med Surg, you'll see in the gray 600 beds. That's our bed capacity for the Med Surg. And you can see the peak that occurred around April 7th, but you can also see we never exceeded bed capacity. On the ICU side, you can see on the orange shaded was our bed capacity. And what you see is an increasing amount of bed capacity. You see the blue rising. And so as we predicted needing more ICU beds, we in a period of 2 weeks at Oxford, and this occurred throughout the city, LCMC and EJ, we increased our ICU capacity about 100 beds in 2 weeks, so that we never exceeded ICU capacity either. I think the importance of that is that because we worked as a city, and if EJ was going to be in trouble or Turo was going to be in trouble, we agreed to accept patients so that no one hospital would ever have to undergo crisis standards. And so we didn't, within the city of New Orleans, ever have a hospital have to undergo crisis standards. And at Oxford, we never had to undergo crisis standards. This was a very difficult time for us. I will tell you, I've been a pulmonary critical care physician for 22 years. I actually worked the ICU at Oxford for Katrina, where I worked 7 days straight during that crisis. And I will say that this pandemic is like nothing I ever saw in my career. I don't think anyone has ever saw in a career, when you're admitting 30 to 50 critically ill patients a night and not having effective treatments. The separation from the family, the incredible sacrifices by the nurses and the physicians and the therapists that put their own life and their own family at risk to care for these patients. It really, it's inspiring. They really are healthcare heroes for the work they did. So I appreciate the time for us to share, and we're happy to take questions, because really we wanted to really have this be give you the ability to ask questions about the data that Ebony has presented, and I'm happy to take questions.
Thank you. Are there any questions for the Ochsner team? Okay. Thank you, Dr. Ebony Price Hayward, for the update, and to you, Dr. Swanee, for your services and for providing us with an update. My understanding is that you all are preparing some written report or response that you'll be providing. If you could share that with the task force, greatly appreciate it.
Thank you.
Thank you. Okay, next on the agenda, I think it'll be something fun to lighten up the mood. We're gonna have Dr. Derek Riveras who co-chairs our Communications and Messaging Subcommittee. And I know that committee's been very, very busy getting messaging out. And so he's gonna present on behalf of his subcommittee an update on what they have done since the last time we've met.
Thank you so much, Dr. Brown. And We had the pleasure of re-meeting for the first time. We've been doing this subcommittee work for so long, and we hadn't even physically met until a couple of days ago over at LSU, and it was a treat. And, we certainly appreciate the work that you and Dr. Levy are doing. I'm going to go ahead and start with PowerPoint. This is our subcommittee report. Lenore Carroll, who was not on the committee the last time we presented, is a new member. She works with the United Homa Nation. Dr. Keith C. Ferdinand, who you've heard from already, we'll hear from again. Dr. Corey Hebert, Councilwoman Helena Moreno is on our committee, and Sadie Finkel has been filling in for her and doing a fine job. Councilwoman Cindy Nguyen, myself, Ms. Janine Tate, who has put together so much of what you're going to see today, Dr. Brown, of course, and Dr. Levy. We thank you all. And before I begin my report, I asked Dr. Ferdinand, he's already made a couple of comments, but I asked him to make a couple of comments relative to the report we heard earlier in terms of vaccination. We've had a lot of discussion about how we're going to message that, and I wanted to give him a minute or two before we get started.
Yeah, all I need is a minute. I spoke earlier. I think we should continue to have the structure in place to deliver a safe and effective vaccine. I'm just not sure we have a safe and effective vaccine, and I don't think the trusted messenger concept is important, but we won't be trusted messengers if the vaccine is neither safe nor effective. So I wait that hurdle before I'm going to say that we should move forward. I do think that the committee, and we don't have to make a decision, should consider building in influenza immunization, which is safe and effective. About 35 to 50,000 people die each year from the flu. And you put that on top of the 204 people who have died from coronavirus, and it is another cause of death which is preventable. So perhaps we can embrace influenza vaccine. I'm ready for that. We can continue to develop the structures to deliver a COVID-19 vaccine. I'm ready for that. But I don't think we can bless the actual deliverance of it until we have those safe and effective pathways clarified. There is a method by which the FDA can release something on an expedited review in which they don't have the sample size for phase 3. They don't really know how well it works or whether it's really safe, but they just say so and push it out there. They've done it twice this time. They did it with hydroxychloroquine, and they did it with immunological therapy. And both times the data was weak, but they felt that they need to push it out because of political pressure. I'm not going to cash in my chips, put my name out there just because somebody's pushing me. It's not going to happen.
So, Dr. Ferdinand, let me ask you a question. I was actually going to ask you this question offline, but since you went right to the topic, I asked the question about whether or not the state was going to have a process, a systematic process for vetting the results of the phase 3 trial before releasing it within the state. I didn't hear a direct answer to that question or clarity on whether or not there was going to be some sort of a vetting process that went beyond just the health department. Would you propose that this task force make a recommendation to that effect, that there be some sort of systematic and transparent state level review before moving forward with deploying the vaccine?
I think we have to do that. As you know, Governor Cuomo in New York, and I think also in Gretchen Whitman in Michigan has made that statement that they're not going to release the vaccine for their public until they have independent verification. I think the harsh reality, and it's difficult for humans to deal with hurricanes when in the Gulf and swimming around and it's 85 degrees and partly cloudy outside, to say, what's the problem? The problem is if you have a vaccine that really doesn't work that well, it gives false security. And the other problem, if you have a vaccine that has unknown toxicity, you end up hurting people. But now you've gone out as a trusted messenger and told the people they need to take a vaccine that is neither safe nor effective. I just don't think that's the good way to go. And the main reason you're hearing about pushing out a vaccine quickly is not because the public says we need a vaccine tomorrow, it's because of political pressure. And that's the harsh reality. People don't like to hear that harsh reality, but that's the harsh reality. That's the only reason for doing this thing. I told Francis Collins and George Mensa from NIH on a call 4 weeks ago that the whole warp speed concept is whack. Black people don't like it. They feel already coronavirus is killing us, and now you want to say, roll up your sleeve, let me shoot you with something. It just doesn't work like that. And I'm sorry to be so harsh and so direct, but I've been around a long time. I've seen these type of things happen before, where political pressure pushes out something before it's ready.
I don't think this is at all harsh. We're approaching 250,000 people dead. Okay, I don't think this is harsh. I think this is urgent. If there, and I'm sorry to hijack. I know, Dr. Brown, I know we've designated you to run the meetings, but as a co-chair, I can't make a motion. But if there was a motion from this task force that we adopt a recommendation to at Louisiana make a similar policy to what was done in New York, I would certainly appreciate that motion.
So moved, Dr. Leviste.
Second.
And we can certainly approve that by acclamation. Are there any opposition? Okay. And so Dr. Leviste made the motion and Pastor
No,
Theron.
I didn't make the motion.
I did. Theron Jackson, I made the motion.
Oh, Pastor Jackson made the motion. And it was seconded by
Derek.
Derek Rivera's. Okay, thank you. So
We can continue. I really wanted to have Dr. Ferdinand address Dr. Welch's presentation, because we spent a lot of time in communication deliberation. We're still meeting weekly and talking about what our messaging is going to be and how we're going to distribute different messages. And so vaccination it's on the back burner right now. We're taking some of the other messages right now, but we're already planning what that will look like, much along the lines of what Dr. Welch was advocating. So here are some updates, and I'll go through these fairly quickly because we've got some of the question and answer in the front. We'll go quickly so to save some time. One of the major changes that we did was a revision to the logo. We felt that the logo looked more like a letterhead and less like a logo, and so now you see the new LA COVID-19 Health Equity Task Force logo that we will be using going forward in all of our communication pieces. We've contracted with Lamar Advertising for a 12-week run of rotating billboards. These are those electronic billboards, and I'll share locations with you at the end of this. But here are several of the billboards that are running with target audiences being Blacks and African Americans, Latinx, Hispanic, Native Americans, Asian Americans, other minority groups, and other disadvantaged and disadvantaged individuals. COVID-19 affects us the most. Mask up, get tested, practical social distancing. We've got locations throughout the state. I'll share a map with you in just a second. Another billboard myth: getting tested will give me the virus. False. The fact is, getting tested will let you know if you have the virus. We try to create catchy, succinct messages that people could see, could resonate with, and also try to get a cross-section of different members of our targeted communities. And so you see the locations there: Baton Rouge, we have 2, New Orleans 2, Lafayette 1. Houma has 5 different areas, but 1 pricing, and Bossier City has 1, Alexandria 1, and then Monroe 1 as well. We did not do Lake Charles for the very obvious reasons of the storm. This is a map that shows that we've crossed the state, and Reverend Jackson, I hope you can hear me. We didn't want to leave anybody out, so we've gone from the north to the central to the south and a bit to the west. We will be going back into Lake Charles when it is appropriate. Here's the budget that we've expended. We had an original budget of $150,000. At present, we've spent $61,650 for a total of 12 weeks of advertising at those locations that you see there to the left. We also have done some social media and other targeted marketing using some of the commercials and ads. We shared a commercial with you the last time I was with you. This at the social media piece at a nominal charge of $12,000 for 3 months. That started yesterday, actually. And then we spent $45,000 developing some of these social media pieces and announcements. We've got a contract for 20 videos. We've already got 2, I think we've got 4 in the can, as they say. and we're going to roll out some more. I'll share one with you as I wrap up. A total expenditure to date of $118,650, and we do know that this budget will probably take us up until the end of this year, this $118,000 expenditure. And then the beginning of the year, we'll look at whether we need to increase it further. So social media contracted through the Advocate, and we've got media presentations for 4 months through that $12,000 that I shared earlier, targeting Instagram, Facebook, and others, and hoping to get our message out broad and wide. And if you have seen it, let us know what you think. If you haven't seen it, please hit us up so that we can make sure we get into the places where you're frequenting as well. Several websites. Here's another one of our ads. When you wear a mask, you protect them. Again, with the various cultures being represented. We're also working on translations in Vietnamese and Spanish. Mask up the right way. Always cover your nose and chin. Very simple, quick messages that people can see and can hopefully remember. And then again, the myth about you will get the virus if you get tested. We have not, as I said before, we have not entered into the vaccination portion of our marketing, and it's largely based upon some of the concerns that have been expressed already about the speed at which the vaccines are being developed and the likelihood of people participating. But at the appropriate time, we will go ahead and get in that area. And so I want to share with you now the Facebook page that we have. Let's see if I can get out of this. And some of you have already found it, but if you haven't, a real quick look. And I didn't show, I'll show you, I'll put the web address up again, but you can see it there at the top. But this is us, the Louisiana COVID-19 Health Equity Task Force Facebook page. And if you go to that page, you'll get updates. We have several, the last one was an hour ago, actually, and that's our meeting started. It was on that Facebook page. Bits of information that you'll find relevant to our conversation discussion, as well as governor's updates and other bits of information. Here's our latest video piece. Let's see if that plays for us.
Started this race. We thought the finish line was close. But now we realize it's a marathon, not a sprint. Follow the science and wear that mask. Remember, we're all in this together because it ain't over.
And that's kind of our tagline. And I don't know how you feel, but we've noticed that there are some folks who feel like it's over. And we keep saying over and again that it's not. We still need to wear our masks. We still need to be responsible. We still need to do the social distancing and all the other pieces. The last thing I want to share with you, and then we'll take some questions, would be the billboard locations. And I think I can do it this way. Let's see. Okay, do you see I-10 and Essen on your screen now? Dr. Brown, you see it? Okay, so this is the one of the Baton Rouge billboards. It's at I-10 and Essen, and I'll go through this real quick for you. This is a New Orleans location. For those of you familiar with the Smoothie King Center coming up over Claiborne. This is the high rise, which I was pleased. Last Friday, I was in New Orleans and just going over the bridge as I normally do, and looked up and I saw a billboard. I was real thrilled. And thanks again to Janine for all the work that she's done. She's negotiated that price that we got for the billboards, by the way, is phenomenally lower than what it would normally cost to do this. These are our Houma locations. Is that right, Lenore? Is that Houma? West Tunnel Boulevard? I think that's Houma. And then as you come over the bridge, West Main Street, also in Houma, and these will rotate. All of these signs have other advertisement with them, so they're up for between 4 to 6 seconds, and then they rotate around with other ads. And you all do realize this is political season, so we were very, very fortunate to get the spaces that we got. We got some prime real estate all through, and this again is the last one in Homer, Grand Calhoun. This is a military highway. This is in Alexandria, going toward the airport. Roseline Avenue. Monroe, I'm sorry, I didn't see that. Went too fast. But this is the billboard here in Monroe. Airline Drive in Bossier City. And the last one I think is Lafayette, Gilboa Freeway. And so I'll put the website address up again for the Facebook. You can certainly go to that page and get this information, as well as we get new social media pieces, including our videos and commercial messaging. We get those out, you'll see those there first. That concludes my presentation. Board committee members, do you all have anything else to offer?
Derek, this is Terry Davis. Very cool messages and images. I love the images. Connie Arnold and I have been doing a lot of work with rural ministers and FQHC CEOs and Council on Aging folks. It seems in rural areas, the problem with masks is with white folks. And I just wondered, besides Facebook, what's the plan of moving to influence folks in rural areas?
Well, again, it's gonna rely heavily on that social media. We're not doing the billboards throughout in every city or every town in the state. That's not practical. So we're gonna have to rely on those social media blasts, as well as any commercials that we use. Commercial airtime, we're exploring, including radio and TV, and those will be relegated again to the larger media markets. But the rural areas are going to have to rely on social media, and we have not targeted any of the messages to any one particular group. They're open to any and everyone, so hopefully they'll pick up on it.
Well, let me just say, Terry, I think there's you're talking about being harsh and being for real. If you look at the rallies that are being held by the president, and those folks aren't wearing masks, all you have to do is drive around the community to see where the Trump signs are. Those folks are not going to wear masks, no matter what messaging give to them. So that's the reality. That's the vacuum that we're in. But I think, to your point, you're keeping the message wide and keeping it universal is the right way to go. But that's the reality that we're in.
Yeah, the other part of that is we learned very early on.
I already have an account with Adobe.
Lenore, you're loud. Lenore, she can't hear us. But we learned very early on that the Black population is much more compliant with mask wearing than whites, and that's not rural or urban or suburban. That's in general. But we do have, as Terry pointed out, we've got to make sure, it does us no good if others aren't wearing masks. We've got to get everybody doing that.
Okay, are there any other questions for Dr. Rivera's? Great work.
Dr. Brown?
Yes.
I just wanted to tell Dr. Rivera's thank you. They did a great job.
Well, we're done, bro. If Reverend Jackson is happy, we are done. That's all I wanted to do was get an amen from the Reverend. Thank you, Reverend. I also want to thank Dr. Brown for joining us and helping us push through my requests. We had a tight time crunch to get the billboards up, as I said, with all of the political campaigns going. And so that was important for us. And we thank you and the governor's office for helping us get that done. One last piece, given the political climate that we're in, it's going to be important for us to make sure that we do as much messaging as we can in the midst of all the other messages that are going out. I couldn't say it the way Dr. Ferdinand said it, but November 1 is a curious date for me.
So we'll be sure to let our donors know how we're utilizing the funding and, set that as a priority.
Thank you.
Someone in the chat. Is that anything? Is that the chat? No. Okay. Okay. There's a comment from Dr. Williams.
Dr.
Still the feedback. Okay. Okay. Just wanted to say great work. Of course, I echo the sentiments for the comms subcommittee. I guess my only request at this point would be, it's such great artwork. And this is something that obviously we all have different groups that we work with. Janine, I'm not sure if she's on. Is there a portal, an internal portal that could be established where we could upload the images of the logos, the artwork, any other things, so that folks who are operating as members of this committee may be able to utilize those, especially when you're going out to, say, your FQHCs, in the hospitals that you visit, and just to help us maximize some grassroots marketing efforts. Janine, is that something, or Dr. Riveros, is that something that we could do?
This is Janine. Absolutely. It can be under our resources tab. So now that we have these out to the public, we can go ahead and upload those. I'll also create a Dropbox with some more materials as we get those in that can be shared internally.
Okay, that's great. And if everyone on here, members of the actual task force, if you could even think about ways that you can help promote this message in your respective areas, I think that would certainly help us, especially in reaching some of those audiences that we've been discussing that need to be reached.
Okay, thank you, Dr. Williams, and thank you again, Dr. Riveros, and your committee. We're moving to the next subject item on our agenda is an update from the Racial Disparities in Healthcare Subcommittee, and that's co-chaired by Dr. Rebecca Gee. And I know her committee has been working ongoingly, and so she's here to give us a brief update.
Great, and first I just wanted to say that if it wasn't difficult or hard, it's not worth tackling, and I think that's exactly what this group is here for, and I really appreciate the honest discussion today. I am heartened in a time of great difficulty in our country by not only the existence of this group, but by each of you and your leadership, and it gives me faith that we will do our best here in Louisiana to protect everyone, regardless of the color of their skin, regardless of who they are, or where they come from. And I'm glad that we have this A-team, these Avengers on the side. And so I'm glad to be a part of this group. I'm going to just be brief because it's been a long discussion and a very important one. Just to say I'm very, we had a lovely discussion last week with Secretary Phillips, with Dr. Duma, with Chief of Staff Tanya Joyner, and with Dr. Benjamin Robinson and others who expressed great support about our ideas. And I think that we have some really fantastic recommendations that we have gone over in the past, so not to belabor them here, but just to say that despite the fact, and I really enjoyed the excellent presentation from Ochsner, that we didn't in fact have crisis standards of care in the sense that there were never ventilators that ran out. There were still decisions that were made due to either perceived or real scarcity that need to be addressed ongoing. And so I think addressing crisis standards of care going forward was a very important discussion and one that I heard support for. We also talked about our pipeline for physicians and nurses and health leadership, that we have to look like the populations we serve. And for that to happen, we must have active measures. Just continuing to do what we're doing will not be adequate. And we discussed some really interesting programs that Secretary Phillips had been very familiar with in Nebraska, and other ideas that we've come up with. And she was supportive of concepts, and we'll be reviewing those. And then finally, we talked about the public purpose of partnerships and some of the community benefit proposals that we put forward. That there is a great deal of money that is saved by hospitals that don't have to pay taxes, and so as a result of that, they're supposed to do community benefit. But particularly Dr. Davis, who's been with us, I don't know if she's still on. I see her, and Christy Anderson, who I see, had some wonderful work that they did, really coming together, coming up with some very concrete recommendations about how community benefits should be required to be reported, should be transparent, and then ideally, and we have a vision for this, ought to be aligned in key areas that achieve health equity. So I think they're great recommendations. They're actionable. I think Dr. Maupin, who's my co-chair, is with us, and he may have additional points, but I really enjoyed our time. Was glad that Secretary Phillips prioritized that at a time like this. And I I checked in with Tanya Joyner today, and she said they are reviewing these with the governor. And so although we did not hear an answer back, I expect that we will, and that we will be moving forward on some of these recommendations shortly.
Thank you, Dr. Gee, and thank you for the work of your committee. And last on the agenda item is Secretary Robinson. Although Secretary Robinson often reminds us that her expertise lies within the Department of Revenue, she has quickly become an expert in health disparities. So she's been serving as the task force liaison, or our go-to person to the governor. And she is here to give us an update on the task force funding priorities. As you're aware, the governor's COVID-19 response fund is funded through the Irene Pennington Family Foundation, the Baton Rouge Area Foundation, and the Huey and Angelina Wilson Foundation. And these funds, which are approximately $500,000, have been allocated to support the work of the COVID-19 Health Equity Task Force. Secretary Robinson, can you give us an update on the task force funding projects?
Yes, Dr. Brown, and thank you very much for having me today. And as you heard already from Dr. Rivera on communications and messaging, their 150 has been the bulk of funds that have been spent out of the 500,000. And I'll clarify that actually the task force received 750,000. 250,000 went to fund the Ochsner prevalence study. And so that funding was already expended for the Baton Rouge area prevalence study that Dr. Ebony Price Haywood, I think your team was a part of that. And so that brought us back to the 500,000. In addition to Lamar Advertising, The Advocate, Doc Griggs Enterprises, we've also done the contract with the LSU Manship School that was approved by the task force for their research proposal on Black and essential relational maintenance and coping strategies. That's 18,000. And we have the contract with the Southern System for the services of Miss Taylor Darrow and Miss Tate. And so we have expended a little over 165,000, and we have approved funding for the Health Equity Dashboard. Dr. Benjamin Robinson had to drop off to go to another meeting, but he and I were able to have a follow-up conversation on where exactly we are with the dashboard. The Department of Health is actually creating a dashboard through the Office of Public Health with the same entity. And so with my sidewalks, and what they're doing is incorporating some of the same items that were suggested by the subcommittee. So as opposed to spending funds on the dashboard or two different dashboards, it will be that single dashboard that the Department of Health is already providing. And so that subcommittee will meet and go through to make sure that they are including the items that the subcommittee had planned to have in the health equity dashboard, be a part of the LDH OPH dashboard. And there will be a follow-up with the plans of using the Policy Link proposal to partner with my sidewalk to do some additional community engagement to utilize that dashboard when it's ready. So the plan, I think, is for some additional parts of that dashboard through the Department of Public Health to come online in November. And Dr. Benjamin will be meeting with his subcommittee and coming back with additional updates on where that dashboard is at the next meeting. I think their meeting is scheduled for Thursday or Friday of next week with the Department of Public Health staff that's working on the dashboard. So that is everything that we have currently allotted funding for. And there, we're right at about $284,000 in funds left. There were some recommendations in some of the proposals to do some work. And so one of the things that we've started working on and looking at is the possibility of some additional health policy work that would look at the disproportionate impact of COVID on economic security of minorities, in addition to the cost of COVID on the minority community, and looking at getting the research done on that by 2 different organizations and using some of those funds to pay for those organizations doing the research. Those organizations including the Data Center and LPHI. So those are 2 of the options, as well as then working on a legislative package based on some of the recommendations that came out of some of the subcommittees. And I'm not sure if Representative Dustin Miller ever joined the meeting or Senator Barrow, but legislation on standards of care for nurse practitioners and expanding those. So some of that legislative package may include lobbying initiatives that the task force may be considering. So those are some of the things. There are funds left for the policy work and presenting all of those policy proposals. And that is the budget update.
Thank you, Secretary Robinson. We just wanted to share with the task force how the funds have been used, how they're allocated, and what we can project to fund in the future. Are there any questions for Secretary Robinson? Are there any public comments, Tracy? No public comments. Dr. Levis, any?
The only thing I wanted to say is I just wanted to thank each and every one of you for the seriousness and diligence that you've shown for this important task force and the work that we're doing for the state.
Boy, you know you gotta have mask. You keep on acting like you ain't got no mask. You can get that.
And whatever it was that she said. So that was all that I wanted to say.
Thank you. Thanks, everyone. I know we had a packed agenda, but we got through it in less than 2 hours. There were no public comments. And again, I just echo Dr. Levis that we're very, very grateful, very appreciative for the meaningful work that you all are doing to make for the individuals and the citizens that we're called to serve. So we thank you again, and we'll post will be. Thank you so much, and have a wonderful
You think that's the one? That's the one you put in. No, we don't. You put a value craft or something.